if you've been to 10 doctors and they all say there's nothing here, everything looks normal, it looks perfectly fine, then what do you say to your partner? My doctor thinks I'm fine, but I just can't have sex with you. Like, that's really, really difficult to say. So then they usually don't tell their partner. And we have studies from Sweden, for instance, showing that about 70% of women never tell their partner.
Could the way your partner responds to your pain, their words, their attitude, their actions in the moment, actually shape the pain itself? And what do ideals of masculinity have to do with why some partners respond in ways that quietly make it worse? My guest today is Linn Myrtveit-Stensrud, a clinical psychologist and researcher at UIT who has spent her career studying vulvodynia in relationships. We get into all of it, the criticism her work attracted when public, what happens to a couple when they have no name for what's wrong, the 3 ways partners respond to pain and why even the loving ones can backfire, and the conflicting ideals of masculinity sitting underneath it all. What I appreciated most is that Linn, a psychologist herself, is the first to name what psychology can and can't explain, and why the moment we call women's pain psychological, we stop looking for the biomedical answers that are actually there. This episode is filled with aha moments, and I know it will resonate with so many of you. Enjoy the episode. So Linn, welcome. I'm really, really glad to have you here.
Thank you.
You have a background in clinical psychology, and you've dedicated your research and your PhD to what vulvodynia does to the partner and the relationship. From my own experience and from talking to so many women in the same situation, I think the partner is often the only, or at least the witness who's the closest to see just how bad it can really be. And yet it's probably one of the least discussed topic within this field. And it's so exciting because your work changes that. And that's why I wanted you on the show. So why did you decide to dedicate your research to this? Like, what drew you to the partner really as the missing piece?
Well, that's a big question. I'm not the first and only to study this, just to make that clear. There is a quite big field, especially in Canada, among psychologists studying partner responses to pain and how different kind of partner responses, if they react with criticism or validation, for instance, towards pain experience and expressions, how that influence pain prognosis and pain intensity and daily function and sexual satisfaction and all these kind of things. So it's not completely new, but for me personally, when I started studying psychology, I wanted to become a couples therapist. So my personal interest was relationships and couples. And then I went into the field of vulvodynia. So it was kind of that way.
Yeah.
I wanted to study vulvodynia, but I had this personal interest in couples and relationships. So I wanted to bring them together. So that was mostly based on personal interest from my side. But of course, I also saw that the partner, like, it means a lot. As you said, they're usually the only witness, the only one who really sees how it impacts the patient in her daily life. And also we know that the partner can play a very big role in treatment and the prognosis of the pain. And I think that's very underutilized because we know we have studies from mostly, most pain patients are women and most pain research is done on men. And we have a lot of studies on how the wives of men with chronic back pain, for instance, can influence the men's pain and work function. So we've had all these studies about how women can support their men. And now we've kind of turned it around and looked at how men can support their women in their pain. And what drew me to especially the qualitative parts, because I've done both quantitative statistical studies on these kind of partner responses and how they're linked to sexual and psychological health, for instance. And also the qualitative studies where we looked at how why male partners sometimes respond more or less constructively to the pain.
Yeah, fascinating. I'm so excited
Yeah, so we can
to
get back to that.
Yeah, I'm so excited to delve into all your research. We were introduced a few months ago, and at that point you mentioned to me that When your research on, I think it was in particular your research on the male partner experience came out, it actually attracted some criticism from some patient communities who felt it was the wrong focus, that like centering the male experience was a distraction from the women who were in pain. What's your view on that? And what does that reaction tell us about how we're currently thinking about these conditions?
Yeah, that was very interesting and also very surprising to me
Mm,
because there are so few people in the field of Vulvodynia. So I've kind of probably been expecting the whole time that I'm always grateful for other researchers, whatever they do, as long as it brings the field forward.
mm,
So I probably expected the same, that people will just think it's great that we get new research and get new funding and publicity. And every time we publish an article, whether it's a scientific article or just in normal media, we usually get a little bit more resources, more money for the hospitals. It helps a lot. But what was interesting was, I think this was last summer. It was I think it was mostly difficult for the people from the endometriosis field. I think that's where it started. That we had some scientific articles on partner experiences to partners of women with endometriosis that went a
yes.
little bit viral on
Yep.
Instagram and
I
TikTok
saw it.
and these kind of platforms. And I thought that I saw that first several times, and I thought that was really sad because I understand where these researchers are coming from and why they do this and how much it actually impacts the healthcare system and how we treat the women with pain. And then suddenly I realized that one of my articles was also popping up on Instagram, on TikTok, in these same kind of reels, and I was kind of shocked, and also I got really stressed by it, and I was really sad. And after a while I also got angry because when these kind of things happen, I struggle a lot with keeping my students in the field. So I've supervised a lot of master students, psychology students, who have written their like master thesis on these kind of subjects. And then when they see that you get a lot of criticism from going into this field, they leave the field and go into different fields. So
Wow.
a lot of them prefer then to research men's lower back pain because then you don't get criticized as much,
Oof.
which is really, really sad. So that's what makes me a little bit angry, that it's so counterproductive to the whole field. But I think it says a lot about how frustrated a lot of women are, how they haven't been taken seriously, and how little research we have and how underfunded it is. So there's a lot of anger, a lot of frustration, a lot of grief. And I think sometimes people just need to take that out on whoever is available. And sometimes that is people like me.
Yeah.
But I also think it's people who haven't understand why we do this, because as I tried to say earlier, we haven't looked into this because we feel so sorry for these partners. We have looked into it because we think they can help decrease the pain in women.
Mm,
So it's all to help improve the healthcare for
mm,
women. It's
mm.
not really about the partners, if we're honest.
I think it's helpful to start out with this to frame the research that you've been doing, because I think that reaction is really telling. I also completely agree with everything you say about it. Kind of points to what I think is really prevalent within a lot of these communities, is there's a lot of anger, a lot of grief, a lot of frustration. But to me, it also illustrates exactly the gap your research is trying to close, because understanding what is happening to the partner isn't competing with the women's experience. It's actually, you could argue, kind of inseparable from it.
Exactly.
So I want to start with something from your first paper that I think every listener who has been through the kind of diagnostic wilderness will recognize immediately. Because in your research, you highlighted that almost none of the couples you spoke to, neither the women nor their partners, had heard of vulvodynia before they were personally affected by it. So here you have these two people who are dealing with something painful and confusing and intimate, and they have no name for it. They're just kind of scrambling for explanations. And what did you find happens within that void?
Yeah, that's a very good point. And I think that's also changed a little bit now because I went into this field 8.5 years ago, approximately. So it's almost a decade ago. And at that time, we didn't have podcasts. We didn't have many web pages. We had Reddit, which is where most of my participants got their information from. And that the advice they got there was just horribly bad. So it is a lot easier now to find information. And I think it takes probably now on average shorter time to get the correct diagnosis, and you find more information when you get it and know what to Google. But back then, and it's still, of course, the same problem that people haven't heard of it before they're diagnosed, probably. But back then, when I started, no one had heard of this. I also lectured for gynecologists who hadn't heard of this. So it was really unknown and this mysterious disorder that no one understood. And when you Googled it in Norwegian, you got you got one link to a Norwegian hospital that said that this pain is chronic. And the first problem there is that people think chronic means forever. In medicine, chronic means more than 3 months. You can have something for 4 months and it's chronic, but it's only 4 months of your life.
Yeah.
So that's a huge misunderstanding. So we try to maybe not say chronic, but long lasting or persistent or something different. And the other thing that it said on this webpage was that it was probably caused, I don't think it even said probably, I think it said it was caused by sexual abuse in childhood.
Wow.
And that was the general assumption when I came into this field and I talked to older gynecologists. They always said that these women had been sexually abused, and if they didn't remember it, then they had repressed it. And they were a lot of my patients come to me because they're a little bit traumatized by the healthcare system. So they have pain and they struggle with their partners and their relationships and dating. A lot of people also struggle with fertility and childbirth and fear of all of that. But I see a lot of women who come because they have trauma from the healthcare system, because they have been met with, of course, painful procedures, but also some of them have been told over and over again that they must have repressed some kind of really traumatic experience. And then they start questioning their own reality and perception of it, and whether they're completely psychotic or if they're not in touch with reality at all. And that's a really scary place to be. So there's usually a lot of worry about that, about maybe something has happened. Maybe you start looking at maybe your parents and your family members and friends and wonder, like, could some of these people have done something to me?
Mm.
And then you're into really dangerous territory.
Mm.
And just to be clear, like repressing, like when you experience trauma, you usually remember it very well. It's not at all common to repress it completely.
Hmm.
So if you don't remember anything like this happening, it probably hasn't. But a lot of people have been told this by doctors who don't really know psychology. So that was a big, big problem to begin with. And also, what I saw very clearly is that when the women didn't get any explanation, they were usually told something like, take a long hot bath, a couple of glasses of wine, you know, let loose a little bit, go downtown, have a few drinks, sleep around. It'll probably just work itself out. And when you hear that over and over and over again, like many of these women have been to maybe 15 different doctors in search of a diagnosis, you never get an explanation. And you try all this poor advice and it gets worse and worse. And then they start thinking that it must be something inherently wrong with them and their perception of pain, their perception of reality, and something they had brought upon themselves.
Mm.
And I meet women who say that maybe I have this because I've had too many sexual partners. I have other women saying that maybe I have this because I've had too few sexual partners.
Mm.
So no matter what you've done or haven't done, people can blame it on themselves.
You explain it so well, and I think this is one of the more quietly devastating but also completely resonating findings from your research, that kind of the lack of language doesn't just leave people confused, it leaves them reaching for like the most painful explanations available. And very often, and like to varying degrees, I see with people I talk to, there's some level of like there's so much mystery around it that there has to be something intrinsically in me that caused this. And it's it's really painful.
Yeah, and then you have the problem with telling your partner. Because if you've been to 10 doctors and they all say there's nothing here, like we've tested you for chlamydia again and you don't have it still, of course, and we don't find anything wrong, everything looks normal, it looks perfectly fine, then what do you say to your partner? Ideally, I think in a perfect world, you will go home to your partner and say, I don't know what this is, but, these kind of sexual activities hurt me. I feel pain with this and this and this. So can we please avoid those things and find some better alternatives?
Mm.
But this is also so stigmatized and so shameful.
Mm.
And if you think there's something really innately wrong with you, then you experience that's the definition of shame, that there's
Yeah.
something wrong with me.
Yeah.
And then it is very difficult to say to a partner, especially my participants in my PhD, they were in their 20s. So a lot of them were in their first or second romantic relationship. They didn't have much previous relationship experience, didn't have much previous sexual experience, some of them. So they were also very unsure. And we know this, that in new relationships, and especially among young people, they don't really know what they want and what boundaries are okay to make. So you lean a lot more on all these social scripts and social norms about how you think your partner expects you to behave.
Mm.
That's also a big part of the problem that we can come back to, that we saw in both men and women. But these women then struggle with coming home to their partner and just saying, I can't have sex because there's something wrong with me. There's something in my head. Like, there's obviously nothing medically wrong. My doctor thinks I'm fine, but I just can't have sex with you. Like, that's really, really difficult to say.
Yeah.
So then they usually don't tell their partner. And we have studies from Sweden, for instance, showing that about 70% of women never tell their partner,
Yeah.
which is really, really sad. And in my study, all the partners had been told, otherwise they wouldn't have participated. But some of them had been told that, I've had pain for the last 4 months, maybe. And then the women told me that in reality, they had had pain for like 5 years, but they couldn't say that to their partner because then their partner would feel so horrible and
Yeah.
broken.
Mm.
And I also saw that a lot of these men, or at least some of them, felt like when they were told that they had had sex with a partner that brought them pain without knowing it, then they felt like rapists and
Mm.
abusers and perpetrators
Mm.
very involuntarily. But they also felt immense guilt and shame because of that.
Yeah. Yeah. And I wanted to come to that actually because the title of, I think it's your first paper, is It's All My Fault. And what
Yeah.
I find so striking is that both sides have spoken to said this, right? Can you tell me a little bit about your findings there regarding this point around guilt and who's to blame?
Yeah. What's a little bit striking actually is that first we were wondering, me and my supervisors, whether this should be one article or two different ones. Could we get interesting results for like both people at the same time, or should it be divided because they would probably have so different experiences? But what we saw was that their experiences were actually strikingly similar in many ways, because they both struggled with understanding what this was, and they both felt ashamed of it. They both struggled with telling their social network about it. They both struggled with sexual intimacy and rejection, and they struggled a lot with this guilt, and they both blamed themselves. And a lot of the men I talked to, or a lot of, like, we don't have a lot of men, it's a small qualitative study, but most of them
Hmm.
said that it would have been so much better if they realized that it was a gene, or it was a virus or whatever, because then it wouldn't be their fault. Because now they could think that maybe they had done something wrong once, which gave her this pain. And especially the youngest men with the least sexual experience, they could tell me that, it was my first sexual relationship and experience. So I was probably so technically bad at
Mm.
having sex that I broke her.
Mm.
And that's also a horrible guilt to live with.
Yeah, it was quite stark reading some of the cases that you brought forward in the research. You interviewed, as you mentioned to earlier, this one man who described the sex that retrospectively, when they realized what had been happening, felt rapey. As you
Yeah.
mentioned, like feeling like a rapist. That is a really big feeling to carry, and yeah, just really significant.
Yeah, and when I lecture about this for students and medical professionals, I usually bring a case from him, actually, his couple, which I think is not in that article. But I talked first to the woman, and these were like 20, 21 years old, young, and it was their first sexual experience for both of them.
Mm.
And she said that I can't just, tell him about the pain and set boundaries for myself. Like, if I get pain during intercourse, I just have to continue, because if I don't continue, if I let him know that I'm in pain, then he will reject me, and he will pull out and, turn over in bed with his back to me, and I will feel so extremely rejected. And then I'm so ashamed because I feel like it's my fault and I'm broken and I've ruined this relationship and he doesn't like me and he will probably leave me. And I thought, "Oh, that's not a very nice partner you have."
Mm.
And then I talked to him a few days later. And what was really interesting is that he talked about the exact same experience. This was like last Friday for them. Like, they talked to me about their last sexual encounter.
Mm.
He said that exactly this, like he had realized a few months ago that she got this pain sometimes.
Mm.
And he felt like he had then, raped her over and over. And when he realized that she was in pain if they had any kind of sexual activity, he got back into this like self-image of being a horrible abuser. And he felt so completely drowned in shame that he
Mm.
just couldn't cope. So he just had to like get out of the situation and away from it. And he just couldn't regulate himself at all. So it was not about rejecting her. It was not about him being angry with her, which she thought he was.
Mm.
But he was so ashamed and so angry with himself, and he felt so horrible. And he was absolutely sure that she would leave him. So they both had very similar experiences in many ways. And this is something, in one session of couples therapy, you could fix. And that's also my hope that better communication, it doesn't take very much to improve this communication. And that would reduce so much of the expectations, the perceived expectations they have from each other.
Yeah, 100%. And that Swedish research that you referenced shows that 2 in 3 women with genitopelvic pain will never tell their partner. What does that secrecy actually drive women to do in relationships? Did you see any patterns in their actions in the face
Yeah.
of that secrecy?
We see this is also something we look at in that article. We use these findings to discuss a new, quite new, it was new at the time, model for understanding the chronification of pelvic pain. Because originally, when these first psychological pain models came out, like 26 years ago, I think the first one, the fear avoidance model, that was based on men with back pain mostly, which states that when people experience pain, they will try to avoid that pain out of fear of triggering the pain again. And what's interesting is that model works very well with most men, and it doesn't work very well with a lot of women, especially the Vulvodynia population. So what some of my colleagues have done, and is to improve that model and adapt it to this female population with genital pain. And we see, of course, that fear avoidance. We see that a lot of people try to avoid anything that might trigger the pain. So in a relationship, that might look like withdrawal, not just from sexual activity, but we see the same as we see with decreased desire and arousal problems in women and men, of course, like they withdraw more and more from the partner because they're terrified that something like a hug or just, sitting next to each other watching a movie or flirting or kissing might be seen as an invitation to sexual intercourse. So they usually like take one step further back all the time. So they start with withdrawing from sexual foreplay and then they stop hugging and then they stop holding hands and it gets worse and worse. So that's a very vicious cycle in a lot of relationships. And we saw that. But what we also see a lot, which is the basis for this new model, is that we also see a lot of endurance behavior. We see that women don't avoid the painful activity, but rather they self medicate or they just grit their teeth and they push through and they have intercourse once a week or whatever they're used to with a lot of pain, which is driven a lot by this guilt of being a bad partner and the shame of not being a real woman and all these kind of social and cultural ideals
Mm.
that influence them a lot. And of course, they have had doctors tell them that they should, have a bath and wine and whatever and just, push through and it will probably improve. So we see a lot of that. Now I
Yeah.
forgot your question.
No, 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 no. That was exactly what I wanted to tease out because that was something I found genuinely hard to sit with, those accounts that you were talking about that just there. And what do you think is underneath that in terms of like the cultural, societal ideas that we have about, yeah, like what are driving these women to actually, as you say, take painkillers before sex just to get through it and like pushing their own limits? Like what is the fear underneath it all?
Yeah, I think this is a very complex question. It's different things. But I think one very interesting sex difference or gender difference is that it seems like in these studies that men are mostly afraid of the pain itself. While when we look at women, they're more afraid sometimes of, for instance, being left by their partner. So they're more afraid of a lot of shame, guilt, and rejection and being left than they are of the pain itself. So maybe different fears and worries, but also a lot of this shame and guilt, of course, comes from cultural ideals about women being there to like please their boyfriends. And we saw this a lot over and over with the women, that they talked about how sex is so much more important for men than women on average. And so it's so horrible if a man in his 20s should go for a long time without sex, and that's considered worse than them having pain,
Mm.
which is very interesting. And I think we also have a long history in our society of minimizing women's pain and not taking it seriously, whether it's childbirth or it's menstruation cramps or it's genital pain. We consider it very normal. And also, a lot of the women I've talked to through the last decade, and also I remember myself in sex ed in school, we were told that when we start having intercourse, it will hurt, it will be painful, because sex is painful for women, at least in the beginning. And I get patients coming to me and saying, what's the beginning? Like, is that the first 7 years? Like, how long should it last?
That's
And I think
devastating.
this is also a very important aspect, that we actually tell young girls to expect pain. And when they experience pain, they consider it normal. And what we also saw in this study, which I don't think anyone else has looked at, is that we looked at how different types of pain onset influenced this coping behavior. Especially we saw that people who had a very sudden onset of pain, they just like one day they woke up and had pain, or they had one sexual experience that was really painful.
Mm.
They understood that this was not strange, like this was normal.
Mm.
So they sought help, they told their partner, they avoided painful activity more often. While about half of the women in my PhD project, at least, I don't know if this is like 50-50 in general. We don't have those kind of studies, but maybe that's something we should look into. The other half of the people I interviewed, they had a gradual onset. So they had this exact pattern of having a little bit of pain the first time they had intercourse. And they consider it normal because they expected it, they had been told so. And then it got just a little bit worse for each month and year. But it was never such a big leap that they felt like, now it's something abnormal that I should seek help for. So they could go for years and years and kind of rationalizing this as something normal and something that probably all other women also experience. And they were the ones that really endured and self medicated and gritted their teeth and pushed through again and again and again.
Very interesting. And now, a word from the amazing partners who make this podcast possible. If you've ever had discomfort during penetration, especially right at the opening, the vestibule, you'll know how sensitive that area can be. And there's a reason for it. The vestibule is densely innervated, it's packed with more nerve endings than almost anywhere else, which is why I find Pelva so clever. Their Hydroslicks vaginal liner adds a soft cushioning layer at the vulva and vestibule during penetration, spreading the pressure out instead of concentrating it on those sensitive nerves. Think of it like a shoe sole for your vulva and vagina. For me personally, having that protective layer genuinely helped me start to feel safe and comfortable in that space again. And you know I will not shut up about ingredients, so I love that there are none of the funky ones in here. There's no fragrance, parabens, hormones, silicones, or glycerin, the stuff that tends to irritate if you have any sensitivity down there. And what I love most about Pelva is who made it. Kelly and her husband Doug built Pelva out of their own experience with discomfort during sex, so they're part of the world's tightest community right alongside us. This is real innovation from real lived experience, and I am so inspired by them. So if you're looking for new ways to feel comfortable during penetration or insertion, Pelva might be one of those things. Head to pelva.com and use the code TWTC10 for 10% off your first order. Okay, back to the episode. I want to spend some time on you've looked quite a lot into like masculine ideals and the interactions there when being in a partnership with a woman who's going through vulvodynia, because this was incredibly fascinating, I think, and it captures something that I hadn't really seen anyone talk about before. You found that these men were often caught between two conflicting ideals. Can you talk a little bit about that?
Yeah, maybe I can first just say something about the background for that.
Mm-hmm.
Because we looked into these partner responses, which is the most studied interpersonal factor in genital pain.
Mm.
And we know that we divided up into three different types of partner responses, and we know that those influence the woman's pain,
Mm.
their prognosis, their pain intensity, their depression and anxiety, and like just everything. And we have these negative responses, which is one type, where you, for instance, this is like how you respond to pain expression during sexual activity. So, for instance, like the first couple, you might, as a partner, just dismiss the pain, or you might even be so critical that you say, I'm so tired of you always being in pain. Like, can't you just take some ibuprofen and, act like a normal woman?
Mm.
Or like, if we don't have sex at least twice a week, like, I will leave. Those kind of responses. We know that those increase pain, they increase depression, they reduce relationship satisfaction, not very surprisingly. Um, and we also have these solicitous responses, which are the very well intentioned responses that also increase pain, which is about focusing, a lot on what's wrong with you, what you can't do, everything that's hindering you. Like I see you're in pain and that's so horrible, and like we should never do this activity again. I feel so sorry for you. Maybe like we should just watch TV and, never have sex.
Yeah. So a
And
lot of
that's
avoidance.
yeah, that's a sort of avoidance from the partner as well. And we know that's it's also not good, but it's usually meant very well. But what we want is partners to respond with the facilitative responses, which is about, like the solicitous responses, they validate the pain, but they also focus on how you can cope with it and increase the self efficacy and it could, for instance, be like, I see that this like intercourse right now is painful to you. Can we find some other position or other activity to do that doesn't give you as much pain, but will still like give you pleasure? Try to find some way of navigating this without increasing the fear of the pain
Mm.
and without shaming. And well, it's very obvious what you should do, right?
Yeah.
But what we see over and over is that this is not how people always respond. They do respond negatively or solicitously. So, what I wanted to look at is what makes partners respond in these different ways, because we know it matters. We know how many approximately like respond in different ways, and of course, you don't always respond in one way. You might be negative and critical sometimes when you're really frustrated, and you might be very facilitative and supportive at other times. But we didn't really have any research on why partners respond in these different ways. So that's what I wanted to look at.
Mm.
So is it when you're really frustrated and depressed, for instance, that you're critical? Or what is it that makes you kind of tick and respond in these less constructive ways? And also, very importantly, what makes you respond in constructive ways? Because we know that involving partners in treatment improves the prognosis for women. So we want partners to get involved, but we need to know exactly what to say to them and also meet them where they are. So what do they struggle with and what do they need to learn? And we know that validation can be learned, but can we teach people how to be better partners for
Mm.
their girlfriends? So that was the motivation behind this. And then one of the things we saw was that some of the factors behind some of these less constructive responses could be very big conflicts between different ideals that they tried to live up to at the same time.
Mm.
And one of the most surprising things, I think, for me was that I also came into this and expected a lot of the men to be very sexually frustrated because
Mm.
they couldn't have as much sex as they wanted in the way that they preferred. And then what most of the men I interviewed actually said was that actually it didn't bother them that much to not have sex, even those who didn't have sex at all. Some people missed it, but it bothered them so much less than I had expected personally, which was interesting. But what really bothered them was that they were afraid that their mates and their peers and friends would find out. And some of them said also, it would be really bad if my friends found out that I live in a sexless relationship. But what would be even worse is if they realize that it doesn't really bother me, because then like I would lose all social status in my peer group.
Interesting.
And one of them even said that he said two interesting things. He said that, you know, if you're the one to like raise your hand in a room full of guys and say, like, I'm the one with a girlfriend that can't have sex, like, that's so much social stigma to pick up. And afterwards, he says that, among guys, and this is, of course, his experience, and not everyone can relate, but he said that among guys, their social ranking and status is very much a product of how sexually assertive they are, or at least how they're perceived to be. So he was very intent of his mates perceiving him as very sexually assertive and competent. And we also know that in our part of the world, in the Western world, social and sexual competence are really intertwined. So if you're considered to be bad at sex, you're usually considered also a little bit socially incompetent. And that's extremely shameful because we're very social animals. So we saw this, that on one side, they wanted to be perceived as these sexually assertive, active, masculine, like traditionally masculine guys. And on the other hand, they also didn't want to be like that inside a relationship. At home, they wanted to be very caring and not pressure their girlfriends and not be some kind of abuser. And these ideals came a little bit in conflict. So they tried to separate them and be caring at home and not be perceived as the same
Mm,
kind of masculine man
mm.
outside the home. So
But
that's the short version.
it's incredibly fascinating, and so I think you've touched on some points that I didn't manage to pick up on in the paper. So much more complexity, and
This
it
is
kind of
really complex. Everything with gender and society
yeah
is really complex. So it's hard to get even in a paper, because you
yeah
have a word count.
exactly. But I think it's such an important point because as we were talking about in the beginning, there is so much that kind of rests on the partner when you're dealing with vulvodynia in a relationship because like as we talked about, it's often that person that sees just the extent of how much it affects the woman. I mean, again, I don't want to play down how difficult it is for the woman going through the actual pain, but there's a lot of responsibility to kind of get it right. And I kept thinking about, I'm not sure if it's Esther Perel. In any case, I think she's the one I've heard talk about how we often in relationships demand our partner to play a lot of different roles, like, best friends, lover, confidant.
The whole
It's
village.
yeah, it came up for me because I feel like this point that you're bringing up around these two quite incompatible ideals of, on the one hand, wanting to be this caring, supportive partner, to step back, to not put too much pressure on, or to protect your partner from any more pain, can be in conflict with the culture that they're living inside of, which told them that, the ideal man initiates sex, is always ready for sex, is like sexually confident. And I thought that was really, really interesting.
Yeah. And of course, a very important part of this is that this hurts men as much as women. Like, of course, I think it's better still to be the partner than to be the one
Yeah.
with the actual pain. But these cultural ideals make it very difficult for both parts. And what we also saw was that since a lot of these couples didn't, I think most, especially young couples and new couples, they don't communicate very
Mm,
well and very clearly
mm,
about what they actually want and what they need because you're so vulnerable in a new relationship and you don't want to be perceived as difficult or like abnormal in any way. So you try to fit into this box, which is quite narrow for how you should behave as a man and as a woman. And we saw that both partners would think that the other one expected things from them that
mm,
they actually didn't,
mm,
but they never communicated about this. So they just
mm,
kept, some of the couples just, kept having sex twice a week because they
mm,
both thought the other one expected it and none of them wanted it.
mm.
So
Yeah,
it
it's
hinders communication so much that we have all these ideals that feel ashamed for breaking.
yeah. And it's interesting. I'm just reflecting of my own experience of this that even though me and my partner have, I would say, very good communication, I can still feel that, some of the things he says that maybe conflicts with what I think is the way every man would think or what they would expect or whatever, like all these assumptions that I have. Sometimes I can't even trust that what he is saying, which is contradicting with what I believe, is actually true, that he's just like saying it to make me feel better or like reassure me. But so it's really interesting how deep these implicit beliefs can just permeate within us.
Yeah, and I can also completely recognize that from own personal experience. And I think that's also what you said, that this is so internalized and is implicit, and we're not aware of it a lot of the time. We just take it for granted. And that's probably also why we never talk about it. And also, when it comes to our sex lives, we usually don't discuss it with other friends and family. So it's a part of our lives that is kind of in a black box, and we don't know what the neighbors are doing.
Yeah.
And we have all these headlines, from the very tabloid media, that
Mm,
like a couple should have sex twice a week, and then like you think you really should. And now people are looking into like that sound like, for me who works with couples, also couples without vulvodynia, that doesn't really sound very realistic. Like, I
mm,
don't know who these couples are. Like, I don't meet those. So, and I know that some researchers have now looked into the selection bias in these studies. So it's probably a lot lower than that. But everyone has heard these headlines and seen them, so they think that's what I should be able to do.
yeah.
And they
Yeah.
pressure themselves to that
Yeah.
because you don't want to be different and you don't want to be wrong.
Yeah. And we've spent quite a lot of time on kind of the patterns that you've found throughout your research, which I think those are hugely validating for a lot of listeners just to have them named. But I also want to make sure we leave some space for kind of the other side of that in terms of what have you seen that actually helps couples navigate this?
Yeah, one if I should say just one thing is, of
Mm,
course, communication.
mm,
Because if I've had couples come in for just one session, and if they both state these things out loud, they
mm,
might realize that none of us wants to do what we're doing.
mm,
So let's just not do that. We want this instead. And they might be completely aligned if they're lucky. And a lot of these couples actually are. So they have been driven to do a lot of things that they don't like just because of these ideals and expectations from society and not from each other. So just stating these things out loud and communicating openly about them can help a lot. And of course, I think if you're the woman with pain, you need to communicate about the pain. And what we also saw with a lot of the men was that they started distrusting their partners because they were told about the pain after a long time, most of them. So they had experienced that their partners had kind of hid their pain, and they felt a little bit deceived and lied to. And they were terrified of that happening again, so they didn't really trust their partners to tell them if they were in pain again. And then they would withdraw from sexual activities out of the fear of causing pain unknowingly. And then the women would be angry and like, I'm finally rid of this pain. And now I want
mm,
to have sex, and now you're withdrawing. Like, what is this?
mm.
So I think it's really important that both parts are open with each other and that they can trust each other to actually set these boundaries and
Yeah.
be transparent.
Yeah.
And that's, of course, very difficult when you feel extremely ashamed of that. So, this is not like a quick fix. It's not like just do this from today and everything will be fine. Like, this is difficult, but I think that's what we have to work towards, more open communication. Yeah, and also, I think it's very worth mentioning that none of the women I talked to felt like this pain was worth it in any way, but they could see that it had come some positive things out of it, like improved communication and an expanded sexual repertoire, and like
Mm,
some of the couples had this like us against the world feeling, and they had
mm,
become closer. But what's interesting is that some of the men I talked to said that even though, it's been painful and difficult and horrible, I think that I've grown so much, and we as a couple have grown so much from this, that it was actually worth it. Some of the men actually believe that. And I
interesting.
think that's also very interesting. And also for all the women who feel terribly ashamed and guilty and feel like this is what breaks their relationship, there are actually men out there thinking that this was actually netto positive. Yeah, I think that's important to hold on to,
It is.
because
Yeah.
a lot of women think that, no one can ever love me since I have this, and I'm just broken as a woman, and like I can't have a family and children maybe, and maybe not a partner. And you definitely can. I meet a lot of couples who have lived with this for many, many years, even for decades, and who have families and children, and they are very content and happy in their lives. So this I usually tell my patients when they say things like this that, you know, all couples have some kind of difficulties.
Mm,
And all the difficulties you can have. It could be, cheating. It could be STDs. It could be personality disorders like or ADHD. Like there are so many things that can be a challenge in a relationship. And of all those things, I really don't think this is the worst.
Huh. Yeah. That's a good perspective to land on towards the end because it can feel like the end of the world sometimes.
Yeah, I know a lot of people have that feeling,
Yeah.
but that's not what I see.
Yeah.
And I know also a lot of couples worry a lot about fertility. That's also something we have looked into, which we're trying to publish now. See how people experience, conception and pregnancy and childbirth and the pain afterwards. And we also see that, if you are able to get to a point where you're able to have intercourse, you're just as fertile as everyone else. You don't struggle more with getting pregnant, and childbirth seems to be very similar whether you
Mm.
have this pain from before or not, because it's a very different kind of pain, and it's also much shorter. It's not this endless persistent pain that you don't understand. It's something very concrete and
Yeah.
short-lived. So a lot of people have very positive experiences with that, which I think is good to add.
Would love to have you back for another episode to hear more about that angle because I actually had a episode not too long ago with a pelvic floor physical therapist about conception and pregnancy and birth with more with vaginismus and like a hypertonic pelvic floor. And I remember we talked about it briefly when we first met that I hear this from so many people that they sometimes have these like comments from often healthcare practitioners who are like, maybe your vulvodynia will just go away when you get pregnant or give birth. And if I remember you correctly, there isn't really too much research on this
There are a lot
topic
of
too.
myths around this,
Yeah.
definitely.
Yeah. Yeah. So I think it's an interesting topic.
Yeah,
But
me too. I've just
yeah.
followed my own life course. When I was in my 20s, I studied relationships in my 20s. And now that I'm pregnant, I'm studying, childbirth. And then, like, I'm just starting a project where we're looking at these symptoms and the role these kind of pelvic pains play in menopause and later. It's like I'm just doing the life perspective,
Yeah. Yeah.
following my own age.
Yeah. But Lynn, as a final question, and I ask this of everyone I speak to who is doing work like yours, what makes you hopeful about the way we are beginning to understand these conditions, about where the research is going, or about how we treat these conditions? Like, it doesn't have to be from your area of expertise, which is psychology, but just in general.
Yeah, I think there are actually many things that make me optimistic for
Mm,
this field. One of them is that, we finally get some funding and
mm,
research money to do this research, which is so desperately needed. And here in Norway, we have recently gotten like a lot of money to do some research on pelvic pain, which is the project I'm a part of right now. And that's the first time I think that the Norwegian Research Council actually gave like really a lot of money for this field. And we also have more vulvar clinics. We have more places where you can go as a patient to get diagnosed. We still struggle a little bit with the treatment side. Like we're getting quite good now at diagnosing, and then still the treatment lacks a little bit. Like you have to
mm,
pay for it yourself usually, and it's mostly private. So there are still lots of challenges, but it is a lot more competence around this now among doctors and pelvic floor physical therapists, and I think also more and more psychologists are looking into this. And I think one of the things that really made me hopeful was actually some of your previous episodes. You talk about with especially like Andrew Goldstein and Jill Kropf.
mm.
Always unsure about the pronunciation of those names, but
Yeah. I hear that a lot.
but yeah, but like follow them from afar for many years, and I think that research, I think a big challenge in the whole, especially women's chronic pain field, is that we tend to put psychological explanations on it.
Mm,
And when we say that something is psychological or psychosomatic or whatever you call it, you could
mm,
call it hysteria if you want, it's all the same. Then we stop searching for the biomedical answers, which are there. I really believe that. And I think it's so great that these two doctors, like, they have found some of these better explanations and root causes. And I'm so grateful that some of the people who can actually go into that field, which I don't really understand at all, I'm
mm,
so grateful that they do that
mm.
because it's so important for all these people I meet also to not blame themselves, to have a clear cause and know that it is because of, if it's mast cells or it's muscular or hormonal or whatever it is, that you get a clear cause. And especially if you can also treat it, but just knowing the cause helps a lot. And I think it's also very hopeful to me that when I started, we didn't have a patient organization here in Norway for these patients. And now we do. They are working politically and they're trying to change the system. And they also help people like me as researchers to recruit participants. So it's much easier for us to actually do the research in shorter time. Then we can do more research and better research. So I think especially those two things, having these patient organizations and user representatives that are easily available that we can collaborate with. And also I think I'm very interested in the biomedical part of this research as well. I think that's really important that we still keep looking for those kind of treatments.
Yeah, that's really exciting to hear from you as well with your background in clinical psychology.
I know better than
Focus
most
on that.
people how much we can't explain with psychology.
But still, very, very important work that you're doing. So thank you for your contributions to this field, and thank you for coming on this podcast. I just think you're absolutely brilliant, and I would love to have you back on the podcast to talk for several more hours.
Thank you for inviting me and for actually reading the research and discussing. I think is really, it gives me a lot too.
How can people work with you? You're based in Norway. Do you take on clients at the moment, or?
I still do for a couple more weeks, and
Yeah.
then I'm going on maternity leave. But when I get back from maternity leave, I will start recruiting research participants. So if there are any Norwegian women out there from 18 to 100 years old who have lived with any kind of pelvic pain who are interested, please participate and get in touch.
Thank you so much for coming on, Linn. It was such a pleasure.
Thank you.
If this conversation meant something to you, please do 3 things for me. Follow the podcast, leave a rating and a review. That's how this work reaches the people who've been waiting for it. And if you'd like to support the podcast directly and help keep it free for everyone, you can do that through the link in the show notes. We're running a bit of a campaign right now where anyone who becomes a monthly contributor to the world's tightest community gets some really cool founding member merch. So do go check that out. And thank you so much for listening. I will see you next week.